Good morning and welcome to the second session of the NSHD birthday celebrations. I'm Alan Hughes, I'm the Associate Director of the MRC Unit for Lifelong Health and Aging. And today we're going to be hearing about the brain and the heart. But before we come on to the talk, here's a short video to show you how to post questions.
You will be able to ask questions throughout the talk session. Please type your question into the box below the video screen. And press submit. You will see a message pop up that says your response has been recorded. Your question will have been sent to a member of the NSHD team who will pass it on to the chair to read out. If you would like to submit another question, then please click here and you will return to the main screen. All questions are anonymous. Please note that due to time constraints, we might not be able to answer all your questions. However, we will be creating a document of the most frequently asked ones, and this will be available on our website.
Great, I hope that's clear. And I should say we're really looking forward to having your questions. So as I said, the talks today are going to focus on the brain and the heart, and I'm delighted to introduce John Schott and Sarah James, who are going to be giving a talk about the findings and plans around the brain in NSHD.
So thank you very much for the introduction, and may I take this opportunity for the first time to wish you all a very happy birthday. I'm here with Sarah James, and we're going to discuss some of the findings around brain health and cognition, and particularly from a study that many of you have been involved with called Insight 46. The brain is a completely extraordinary organ. Here is a picture of a brain, and the brain controls everything that you do, everything you see, everything you hear, and all your thought processes. And of course, as people get older, it's inevitable that because diseases of the brain are more common in the elderly, that people's thoughts turn to the cognitive changes that accompany aging. And we now know that as people get older, that the concerns about cognition, about dementia and Alzheimer's disease really become one of the major things that they fear as they get older. And so as part of this, of the program of work that we're doing, as you have got older, so we have begun to address memory and thinking and how this can change and how this can be preserved as you get older. So if we take a very broad overview about how we think about the changes that occur during aging, what we think is that there are various different pathways by which the brain can age, and there are various changes that can be seen when the brain gets older. And in some cases, those brain changes, those abnormalities within the brain, can lead to cognitive and to functional decline, but in many cases not. And if we think very broadly about what might influence those changes, it comes down to your genes, what you're born with, which we think affects around 60% of your chance of having healthy brain aging as opposed to having dementia or diseases that affect the brain. But also that we know that around 1/3 of what influences your brain changes as you get older are things that you experience during your lives. And of course, all of you who've been followed since you were born provide a fabulous opportunity to try and tease out those different influences, all with the aim of us understanding what we can do to keep our brains healthy as we get older, and for individuals who may be on the path to developing diseases of the brain, how we can intervene. And the reason that we can do that now, and we can do this at a stage before people have any symptoms, so we can interrogate the brain changes that might be occurring in aging when people are still healthy, is by using biomarkers. So these are biological techniques that we can begin to investigate those brain changes, which we can do taking fluid samples like blood tests or spinal fluid tests, And we can use this using very sophisticated brain scans that can look at different proteins within the brain, that can look at small strokes within the brain and look at the structure of the brain. And of course, we can use very sophisticated cognitive testing, so memory type testing, as well as some of the paper and pencil tests that you've done throughout your lifetime, and also sophisticated electronic measures like wearables, things that you can wear, and we can measure function. So in order to explore this further, we set up a study to try and address some of the key issues about brain health, which is to ask the questions: why do some people develop cognitive problems as they get older? Who's at risk, and when might they experience problems? What can we do to improve brain health, and how can we test new treatments to try and prevent people developing dementia? So with this in mind, we designed this study called Insight 46. And we invited 500 of study members to come to see us here at University College London in a longitudinal study. So this was a study when people came twice, around 2 years apart. And we selected people very much at random based on individuals who'd taken part in the study throughout their lives. And we had most data information on, and people were willing to come to London and to have brain scans. And we did a whole suite of different tests, including measuring memory and thinking, doing lots of brain scans, looking at the genetic side of things, measuring your movement and walking, taking various blood and urine samples, doing a physical examination by a neurologist, and of course then extrapolating and taking that back and linking it together with all the information that we've collected over the last 75 years. And those of you who took part will recall that you had a brain scan, and in that brain scan we were able to measure a huge number of different aspects of your brain health. We could look at your brain structure, the networks within the brain, we could look at blood vessel damage, we could look at the accumulation of proteins, and particularly this protein called beta amyloid, which is related to Alzheimer's disease, how the brain is connected, the blood flow, and little bleeding within the brain. And then what we aim to do is to take all this information on the left-hand side here, all this information that we've collected over the last 75 years, and then add it together with this new, very detailed information to try and gain some insights into brain health. And I'll now pass over to Sarah James, who did a lot of these assessments, just to talk you through a little bit what this involved for the 500 people who took part.
Hi, so I'm going to take you through what the experience was like and who attended. So the first thing we did was organise with you the best way for people to get to London, where the assessment took place. And for those who weren't local, we helped organise a stay in a nearby nice hotel. And then on the day of the assessment, we provided some instructions and help to get to the assessment centre, which is located in the middle of London near Russell Square and the British Museum. And there you would have met one of our study team members. So this is a team of clinicians, psychologists, researchers and support staff that some of you might recognise. So one of the first things we do is to go through the consent form together, where we emphasise that your participation is completely voluntary and you can stop at any time. And then we did some physical tests of things like your limbs and walking movements, and we took blood and urine samples. We also performed some cognitive assessments. So we did some standard cognitive tests, such as tests for memory here and reasoning. We also did some more novel tests with computer assessing things like spatial recognition and multitasking that some of you really enjoyed or loathed. And at the end of the day, we took you to a nearby hospital where you would have your brain scanned for an hour. So who took part? So in the first wave, which happened between 2015 and 2018, we were aiming for 500 people to say yes to attend this sub-study, and actually 502 people said that they would. So that's fantastic. And so you came from all over mainland Britain. So on the left there is a map which shows the general areas where people in the sub-study come from. And what's really nice is that this geographical representation is very similar to the general population in the UK. So that's fantastic. And so priority is our priority for this study is your safety, and we have a strict duty to report on clinically relevant findings. So if in the case we did find something, we let your GP and you know if you gave us permission to do so. So these could be investigated further in your local services, and we wrote a paper about those findings here. So we had funding to repeat this assessment 2 years later, but this time we were also able to add new measures, which included assessing things like blood flow, the structure of the heart, sleep, wearables, forgetting, and a lumbar puncture, which of course, again, everything is completely voluntary. And we were doing really well. We had 85% of people come back to the research centre and attend, until March 2020, where, of course, the pandemic turned our world upside down. And given that our priority is safety, we were, of course, unable to continue the assessments as normal, and lots of us got involved in more clinical duties. So with the strict guidelines in place, we adapted some of our assessments to do some remote assessments with you over the phone or computer, and some of you really helpfully took part in that, so thank you. So all in all, we had 442 people come back for the follow-up assessment, which is about 88%, which is fantastic. And so we just really want to take this opportunity again to say a big thank you for taking part. So I know lots of you enjoyed the this imaging sub-study, and we also just really appreciate your feedback and your willingness to take part.
Thank you, Sarah. So I'd like to now just share with you some of the key findings of the study. This is an enormous piece of work. We published over 20 papers so far, just looking so far at the first wave of the assessments, with many more to come. So I'd like to thank you again for all of your participation. But understandably, you'd like to know some of the things that we found. So I'm going to give you just 3 examples of some of the findings from the study that you've contributed to. The first, and one of the headline findings, is that we could show by interrogating the blood pressure measurements that you'll have had done in your 30s and your 40s, that it was your blood pressure, even that far back, that was beginning to influence the findings that we saw on your brain scans some 30 or 40 years later. And this resulted in a major paper in the top neurology journal, The Lancet Neurology. And many of you that will have seen that there was coverage in the press, on the BBC, and the foreign press media as well. And this work, it has been proving very influential, and is really part of a very large bit of work now that is linking together heart health with brain health. And is helping to contribute to the public health messaging, and particularly at a time when the government were planning to stop measuring blood pressure routinely in GP practice in the 40s, to put this very much back on the agenda, that blood pressure is important for not only for your risk for heart attacks and strokes, but also for brain health, and perhaps in due course for dementia, and it's blood pressure really in your middle life that's most important. There's been a lot of reports in the media that your hearing and your sense of smell may be risk factors for subsequent dementia. This is a controversial area which we've been able to contribute to, finding that no evidence that your hearing assessments that we did at these assessments, all the assessments of sense of smell, related to any of the brain findings on the scans or on the cognitive testing that you kindly carried out. We were able to link together some of the memory testing that you had done as children with how you were performing in later life in your 70s. And we found that, as expected, that there was a link between how you performed at the age of 8 and how you perform at the age of around 70. But also importantly and independently, we found that the amount of education that you had another independent assessment. And again, what we want to do in this study is to provide meaningful outcomes that can influence health policy and research moving forward. And this is yet more evidence for the influence of education on brain health in later life. And one of the unique aspects of this study is that we do have those measures throughout your life course. Finally, I'd like to just talk a little bit about blood markers of cognitive health. Many of you will be having fairly routine blood tests, screening and looking for various other conditions, for looking at cholesterol, looking for diabetes. And one thing that's eluded us for many, many years is the chance to look for blood markers that might reflect your cognitive, your brain health. And this was really unheard of or felt impossible even to a couple of years ago. But we now have been able to harness very sensitive bits of kit. This is a Simoa on the left and a mass spectrometer on the right. The details aren't important, but what's important is how sensitive these are. And so on the top panel here, we've got a gram of salt, and on the right, we can dissolve that so you can't see it in a mill of water. But the Simoa machine on the left can detect 1 gram of salt dissolved in 1,000 trillion liters of water, and the mass spectrometer 1 gram of salt in 1,000,000 trillion liters of water. And when we use these techniques to look at some of the abnormal proteins in the blood, we can see that it's for the first time quite realistic that we might be able to determine some of the changes that we think may well associate with Alzheimer's disease in the blood. So this needs, of course, much longer term follow-up, but this, and this is a paper that came out very recently, suggests that the holy grail of being able to use blood tests to screen for causes of cognitive impairment in later life, or factors that can protect you, may well be a reality. And this may have major implications both for new clinical trials of new treatments for aiming to prevent Alzheimer's disease, and in due course, how we diagnose these conditions. So there may be many of you sitting there at the moment wondering why you weren't asked to take part in the study. And so if we think about the cohort that you've kindly been involved with as a whole, we've spoken about 502 individuals who were recruited and 442 were seen for a second time. But what about the rest of you? Well, I'm very pleased to say that those of you who have not contributed before and those of you who had, many of you will have the opportunity to take part in this research moving forward, and we very much hope that you would like to do this. What we're planning to do, and we have new funding to do, is to see 250 people who have already come for these assessments for another wave of assessments, but also to recruit 500 more of the study members to do very similar assessments as well. And this wave 3 of the study, for which we've now got a large funding from the United States Alzheimer's Association to study brain health in yet more detail, we will be informing you about soon, and would very much hope that we can see many of you for similar assessments in the future. Finally, it falls on me to thank you all personally for all of your amazing commitments over the last 75 years. Here's a few of our study team in the Insight 46 study team. Happy birthday! Wishing you their own happy birthday. And also just to thank, first of all, the Medical Research Council, who of course funded this work for so many years, but also all the other funders, and particularly Alzheimer's Research UK, who funded quite a lot of the Insight 46 study. And so Sarah and I will stop there, and we're very happy to take any questions about any aspects of the study and what it's like to take part. So thanks again, and once more from me and from Sarah, a very, very happy birthday.
Thanks, John and Sarah. That was great. So I'm picking up the questions from the chat. The first one I want to pose to, I guess, both of you is, if you could go back in time and go right to the start when Douglas instituted this study in 1946, are there any investigations or questions or tests that you wish had been introduced then that would shed light on the questions you're interested in now?
Well, perhaps I can kick off with that. And again, first of all, yet again, happy birthday. I think it's important to start off like that. I mean, the first to say is that the richness of the data that we have from the childhood onwards is completely extraordinary. And we as researchers are the envy of the researchers around the world with what we have already. And particularly knowing about the cognitive tests that were done in childhood really is a unique selling point of this study. And it's certainly one of the things that has attracted a major American funder to want to fund the next phase of the study, because this just does not exist anywhere else. So the first is to say that we are monumentally pleased with the information that we do have already. If I had a magic wand and we could go back again, well, first of all, it all depends a little on the technology that's available at the time. It'd be very nice to do some of the more technologically advanced things that we can do now. In retrospect, it will be lovely to have lots of blood tests stored all the way back to be able to interrogate. And as I say, I can't emphasize how extraordinary is the advances in the blood technologies that we've had over the last few years. And this extends not just about brain health, but lots of the other blood measures that we can measure in lots of other areas of the study. We'll hear about cardiovascular health and resilience and various issues. And so in many ways, the more blood tests that we have going back as far as we can, the better. Our findings about blood pressure in the 30s and 40s are absolutely fascinating. And again, it's completely extraordinary to have blood pressure measured prospectively. So not just sort of guessing or going back to GP records, but all of you having blood pressure measured in the same way has been able to really advance our understanding. It would be lovely if you'd had blood pressure measured in your 20s and your teens as well. But I'll say I'm nitpicking. We're very, very happy with what we've got.
Great, thanks, John. Sarah, is there anything you'd like to add?
Yeah, I think that's a fantastic overview. So I think more things that we're learning about dementia and then thinking about how we could have incorporated that in the cohort are things like mental health. And I think that our understanding of mental health has changed quite a lot over the cohort. So again, I think having the measures we have now back in the cohorts in your teenage years or early adulthood would have been fantastic. And the other measure that's of great interest at the moment is head injury. There's a lot of interest around head injury and sports and things like that in relation to dementia. So I think if there was anything that could go back in time, I would say let's get a better measure of head injury. But as John said, you know, what we have is fantastic, and so we're really grateful of that.
Great, thank you, Sarah. So another question, I think for you, John, that's about dental health and its relationship to cognitive decline and dementia.
Thank you. Yeah, so there's quite a lot of interest in dental health, and one of the issues that, of course, we have with dental health is trying to tease apart the various aspects that go into dental health, because dental health can be quite a good general measure of your health, your access to healthcare, etc. So we do have some questions that have collected some information about dental health over time. We have been approached by a lot of people about doing some more detailed dental assessments. And one of the things that we really, I think, struggle with, and that's everyone who's involved in the management of the cohort, is trying to balance the completeness of the information that we collect from you from the burden that we put on you. We would love to have full dental assessments and eye assessments and huge numbers of different things. And what we need to do is to balance what we think is reasonable that we can collect and not overburden you. So we decided for the first few waves of Insight 46 that detailed dental assessments and the time-consuming nature of those was not something that we could pursue. But we are keen to continue to revisit that, and there may well be also some new blood tests and other indices that might give us some indirect associations with regards to gum health, which can and dental health, which may well help us moving forward, and also the influence on dental health, not just on brain health, but also on cardiovascular health as well.
Great, thanks, John. So, Sarah, I think this next question is perhaps for you, and it's about the relationship between anxiety and the results of a memory test. And firstly, whether anxiety makes you perform less well on a memory test, and if that's the case, how do you allow for that when you're analysing the results of these tests?
Yeah, that's a really good point, and we know that they are related. So especially when we think about something like memory loss, which lots of people are worried about, we really want to capture that. So there's something called self-reported memory loss, where you think that you're losing your memory, and we can compare that to objective memory loss. And again, that's thanks to the fantastic data that we have. So we can see whether actually you're worried about something objective, or maybe there is something, you know, there. But again, because we capture these things, so we ask you to rate your mood and how you're feeling about everything, so we can really take that into account when we do these methods of looking at patterns of associations across the life course. So it's definitely something that we take into account. It's really important too.
Thanks, Sarah. So I think, John, probably a last question for you, and that's, you've spoken about the study moving forward, and there's a question about when you anticipate that participants will be contacted about the next wave. And obviously we appreciate that there's a lot of uncertainty still with COVID, but I'm sure people would be really interested in hearing what your thoughts are at the moment about the timelines looking forward.
Absolutely. So, we're very grateful to receive a very large grant funding from the American Alzheimer's Association to take this work forward and to enter this next phase. And we're very excited to invite some people who've been in the study, who've been in Insight 46 back for a third visit, but also to invite a large number of people who haven't for more assessments. The answer is that we are working on these protocols and finalising things as we speak, and we really hope to start getting invitations out to people within the next month or two. This will be a staggered process, and we would like to start seeing people probably remotely in the next couple of months, with a view that once the vaccinations have taken place, and hopefully everybody in the cohort now will have received their first vaccination and will have had their second vaccinations, all of us who are involved in seeing study participants will all have been vaccinated, and of course we'll take all appropriate PPE type care, that we'll be able to see people face to face in the early summer. So watch out for those invitations. Thank you very much for considering taking part in this research. I hope we've provide some of the real excitement that we have within the study team, but also that the rest of the scientific community does, about the huge opportunities that this has for us, being able to link together all the information in the past with these really state-of-the-art contemporaneous measures. And once again, to wish you a happy birthday, and thanks again for all of your efforts over the last 75 years, and hopefully moving forward as well.
Great, thanks, John. That was fantastic. And thanks again to both of you, and thanks to everyone listening for your questions. And now I'm going to move on. John and Sarah touched on the links between the heart and the brain. And the next talk is going to be from Gabriela Captor, and she's going to focus on the heart in the context of NSHD. Gary?
Good morning and welcome. From all of us at the MRC Unit for Lifelong Health and Aging at UCL, we wish you a fantastic 75th birthday. My name is Gabi Kaptour. I'm a cardiologist and senior lecturer at UCL, co-leading the cardiometabolic research program in NSHD. So in the available time, I will recap some of the salient cardiovascular discoveries that you have enabled, and I'll also outline some of our plans for the future with regards to the NSHD MyFit 46 cardiac sub-study of NSHD. So the heart and cardiovascular system have always been a priority for research within the NSHD. Over the decades, we have dotted you with sticky ECG electrodes, spread gel over your chests to carry out echocardiography, poked your necks in order to scan your carotid arteries in the neck, compressed your arms for blood pressure measurements, and pricked you time and time again for blood samples. We wish to thank you for donating yourselves to all of these tests. We have always been extremely careful to ensure that you would not come to harm from any of our investigations. We hope that you've retained fond memories of all our past meetings at previous clinic visits. Your safety and protection has always been of paramount importance to us, and it will always be. Our second priority has always been to use your rich and unique data for the common good to inform public health and find ways of keeping our hearts stronger and healthier for longer. We have known for a long time, for example, that low birth weight newborn babies tended to have higher blood pressure in midlife. But in 2014, you showed us that this was not simply about low birth weight, but that there actually existed several different growth phases during childhood that were all independently associated with high blood pressure in midlife. You also showed us that there exists important social patterning of early cardiovascular risk factors, such as nutrition, infection, and stress, that were all independently associated with high blood pressure in midlife. You also went as far as to show us that those of you who experienced accelerated weight gain during adolescence were also more likely to develop high blood pressure in later life. And this underpins some of the major public health efforts to combat obesity in the present day. We also studied the integrity of your DNA after extracting it from the blood samples you've provided us, and we linked this information to the information from your carotid arteries and the health of your vasculature. You showed us for the first time that those of you who experienced accelerated cellular aging in middle life tended to have worse vascular damage in older age. You were therefore able to inform us about the existence of a new potential risk factor for cardiovascular disease not previously known about. That is, the presence of accelerated cellular aging in middle life. Thanks to the echocardiograms, which we performed on your hearts at the age of 60 and 64, you were able to show us for the first time that those of you who had higher blood pressure in middle age tended to go on to develop stiffer hearts by older age. This is important because it added pressure on GPs to identify and more aggressively treat high blood pressure in middle life in order to preserve heart health for longer. More recently, we mapped out your personalized trajectories of frailty. In other words, your each individual accumulated patterns of health deficits throughout your life course. We were able to show that those of you who were more frail as children and young adults went on to have poorer heart size and function in older age. The suggestion is that the accumulation and burden of health deficits throughout life insidiously strains the human being and eventually leads to hearts that are thicker and less efficient in terms of their pumping function. This year, we will publish some new research which shows that those of you who had a slow pulse rate as children at the age of 7 were 3 times, had triple the odds of developing electrical conduction abnormalities in the heart by older age. This is important because it suggests that conduction problems in the heart that can sometimes lead to collapse or the need for a pacemaker may potentially be predicted through a simple pulse check in childhood. Finally, this year, we will also publish some data showing that those of you who expressed certain blood markers of insulin resistance, which is the metabolic precursor state for diabetes, expressed a particular ECG signature that correlates with the presence of abnormal heart rhythms and has also been linked to increased risk of death. This therefore emphasizes the importance of healthy diet and lifestyle in order to prevent the occurrence of diabetes and insulin resistance, and of course, their arrhythmic complications. So this was a research snapshot from the past. But what about the future? So fortunately, the British Heart Foundation has now partnered and joined forces with the Medical Research Council, and they are helping us to undertake a cardiac sub-study in NSHD, which is called MyoFit 46. As part of this study, we will invite you to a brief clinic visit in London, where we shall measure your blood pressure, your height and weight, and also collect some blood and urine samples. Then we will invite you to wear this innovative ECGI jacket, which collects a very comprehensive ECG recording from across your entire chest wall, front and back. This award-winning, safe and innovative jacket has been designed and built by us at the LHA, and you are going to be the first cohort in the world who are going to be using it to support clinical research. After undertaking the ECG, we will ask you to undertake a cardiac MRI scan using our state-of-the-art scanner in London. This will allow us to obtain some very detailed and beautiful pictures of your heart that we will use in order to scan your cardiovascular system in more detail than has ever been done before in an older age cohort. Prior to the outbreak of the COVID pandemic, we recorded this video to explain what a cardiac MRI scan involves, and I'd love you to see some bits of it now.
MRI stands for magnetic resonance imaging and produces an electronic picture using a magnet instead of an X-ray. It is safe because no radiation is used. Our group has performed several hundred such scans in this age group without event. The cardiac MRI will allow us to study the heart, both at rest and under stress, in a completely safe way. The stress stage of the test is carried out by injecting a small amount of medication called adenosine. The effect of the medication is short-lived and equivalent to walking up 2 flights of stairs. We will also be injecting a dye, known as a contrast, to allow us to spot any part of the heart muscle that may be scarred or not receiving an adequate blood supply. If you have any metal implants, we will check what type they are. As most metal implants, like a knee replacement or a coronary stent, are not a problem for having an MRI scan. However, other types of metal implants, such as a cardiac pacemaker, are not always safe for the MRI scanner, and so we would not perform the MRI if you have such an implant. Before the scan, a member of our team will place 2 cannulas in your arm to allow for the adenosine and dye to be given later. When you are ready to go into the scanner, you will be asked to lie flat on your back on the scanner bed. ECG leads will be connected to the ECG stickers on the chest, and a blood pressure cuff will be placed on your arm so we can monitor the heart throughout the scan. We will provide you with a button which you can press when you are in the scanner to tell the study team how you are getting on. As the scanner makes a loud noise, we will provide you with ear protectors to ensure that you are comfortable. Once you're ready, we will then slide the MRI table gently into the scanner. The cardiac MRI scan will take around 45 minutes. During the cardiac MRI scan, the researcher will ask you to hold your breath, which will allow for time for the pictures to be taken with no movement. However, for most of the time, you will be able to breathe freely. The MRI scans are safe. A radiographer or doctor operates the scanner from behind a window and will be able to see and hear you throughout the procedure. Some people experience feelings of claustrophobia during the scan, so we can offer to scan you in different positions to make you as comfortable as possible. The dye that is used for the cardiac MRI scan is very widely used all over the world and usually has no side effects at all. The stress medication will exercise the heart gently for 4 minutes. It is perfectly normal to feel a bit warm and flushed and to feel your heart beating a little bit faster during this time. These effects stop within seconds after the injection is given. Our priority is to ensure that participants are as comfortable as possible throughout the cardiac MRI scan. A trained doctor will always be present for the cardiac MRI scan to take care that every participant enjoys a pleasant cardiac MRI experience. Before you leave the scanning department, you'll be given time to rest and ask any questions you may have about the study. We hope this short film has provided you with some useful information about the cardiac MRI scan. Thank you for watching, and we look forward to seeing you at the clinic visit.
So I speak on behalf of the entire cardiometabolic team, and I say that it has been our absolute pleasure and honor to examine and study your fascinatingly complex cardiovascular systems all these years. Not only have you informed the world about the cardiovascular determinants and life course determinants of cardiovascular health, but I also dare say you have given birth to a new generation of clinical scientists, the longevity physician, who, like me, will fight tooth and nail for the maintenance of cardiovascular excellence and health out to the 10th decade of life and beyond. At the age of 75, you are still of enormous interest and value to us, to Public Health England, to the NHS, to the MRC, to the British Heart Foundation, and to global science. We simply cannot wait to welcome you to London in order to kickstart this next exciting chapter of cardiovascular discovery with you as part of the MyFit 46 sub-study. Thank you so much for your kind attention.
Thanks very much, Gabby. Thanks very much for that talk. So again, I'm going to ask you some questions that have come up in the chat. Gabby, are you there?
Yes, I am. Can you hear me?
Yeah, that's great. Thanks. So the first question I'm going to ask is, what do you hope to discover using this MRI technique? And when do you anticipate asking people to attend for these scans?
So with regards to starting the scans, the good news is that we've already started. So between lockdowns, last summer, we had already started recruiting participants, and 4 of you have already attended and undergone this protocol. It was very well tolerated and we had excellent feedback. So 4 NSHD participants have already been scanned. They've had this high resolution ECGI recording. It all went very smoothly, and you all seem to have had an excellent cardiac MRI experience with us, which is fantastic. And it really augurs well for the rest of the study. Of course, the minute the lockdown hit, we had to interrupt that recruitment process. We are now in talks with UCL, and of course we're following Public Health England guidance, but as soon as it becomes safe for us to do so, we will start calling all of you back in. We are hoping to recruit a total of 500 participants over the course of the next 2 years. So we're really keen to get this back up and running as soon as possible. You know, I hope that you will hear from us quite soon with regards to inviting you back for these clinic visits. With regards to the sort of data and information we derive from these scans, so the cardiac MRI scan is, one might say, the Rolls Royce of cardiac imaging. Many of you have had cardiac echoes done before. These are the jelly scan ultrasound scans of the heart. The cardiac MRI, however, is at a completely different level. It gives us fantastic information about the actual health of the heart muscle wall, which is the myocardium, which fundamentally determines the pumping function of the heart. And we are able to interrogate the health and integrity of the myocardium in more detail by MRI than we can using any other imaging modality, which is available currently in the field of cardiology. A cardiac MRI test costs the NHS usually over £500 for a cardiac MRI scan that we perform on patients. If you want to do a cardiac MRI in the private practice, it can cost over £1,000. So we are offering this non-invasive, fantastic imaging test as part of this research. We were grateful, of course, to the BHF for funding the studies. We're also grateful to the European Union because we've also managed to leverage some funding through one of our main collaborators in the unit called Dr. Thomas Tribal, and we will also be able to append additional investigations onto the MyFit 46 study, and that might also include some additional brain scans and possibly also some retinal photography when you come to the clinic visit. So this is all a work in progress at the moment, but we do hope to start offering these very sophisticated but at the same time safe and completely non-invasive tests to at least 500 of you as soon as it becomes feasible. The cardiac MRI tells us things about the myocardium which we can't get by any other cardiac imaging test. So we can detect, for example, if your heart has finite patches of scar, if you've had an infarct. Many people end up having a cardiac MRI and discovering that they've had a heart attack when they never even knew about it, just because we can see the remnant of that scar, even if it happened decades and decades ago. We can also identify the burden of fibrosis in the heart, and we can spot any areas of inflammation in the heart. And now, of course, the fascinating bit of technology, which is the ECGI vest, which is that high resolution ECGI recording, is that for each and every one of you, we will be able to link the anatomical picture and the substrate changes in the heart muscle wall with what is happening at the ECG level. In other words, understand how your heart structure and function in all its detail is impacting the electrical activity and electrical performance of the heart, which has never been possible at the scale we are proposing because the technology was not available previously. But now, hopefully, you will be the first cohort where this will be undertaken.
Great, thank you, Gabby. Gabby, you mentioned about the exclusions for MRI, particularly around cardiac pacemaker implants, and there's a question about whether people with tooth implants can have MRI scans.
Did you say tooth implants?
Yes.
Yes. So nowadays, yes, they would be considered to be safe, and tooth implants are made of a sort of alloy or material which is considered to be cardiac MRI safe, so it should be of no concern.
Great, thank you. And so I appreciate this is going to be a difficult question to answer given the uncertainties, but there's a question about, originally we had planned 3-day visits. And perhaps you could just talk about current thinking about what the visits might look like, because obviously John talked about a brain visit, you've talked about a heart visit. How do you think, how are we considering dealing with the visits in a post-COVID era?
So I think that's a very relevant question. The priority is always going to be the NSHD participants, so it's going to be yourselves. There are some of you who would prefer, for example, to only attend a very brief visit and be here in London for the shortest time possible. And we will be able to configure a clinic visit that suits, that works around that. So we will be able to offer you a morning or an afternoon visit, which is quite focused, where all we do is invite you in for the high resolution ECGI recording and the MRI, perhaps a quick retinal photo, perhaps a quick 20-minute brain scan that shouldn't take more than 2 or 3 hours with us in the department. So that is the sort of package which might be offered to a large number of you. There might also be opportunities at some point in due course to also interdigitate our study with the ongoing third wave of Insight 46. So I anticipate there might be future opportunities where some of you have agreed, for example, to come and attend one of the wave 3 Insight visits, and then perhaps we can add MRI at the very end just before you go home. But these are options that we will discuss both internally as a research team, based of course on the availability of funding and understanding what Public Health England advises with regards to overnight stays and hotels and travel, etc. But as I said, I think the core and fundamental priority for us is always to make it as convenient as possible for you who are attending the visit, and therefore we will always work with you to understand which mode of transport you prefer and which sort of solution works best around your timetables.
Great, thank you. So another question for you is, what do we know about the relationship between exercise taken from midlife and heart health in later life?
So I think that's a really important question. So there are 2 angles to this. Broadly speaking, exercise is considered to be beneficial, and in many ways, it's going to improve cardiovascular health, and it also improves longevity, so how long you live. And the reasons for that are quite obvious. Exercise improves the quality of your arteries and your vasculature. It helps reduce blood pressure. It prevents the occurrence of insulin resistance and therefore diabetes, prevents arteriosclerosis. It lowers your cholesterol, etc., etc. So for all those reasons, exercise is definitely an ally for us cardiologists, and we would definitely advise exercise to people who have to anyone really of middle age and younger even, because that will have a long-term impact on the adaptations of the heart in older age. There is obviously also another side to that coin. If you are a very competitive athlete, there is some evidence that people who compete extensively have a slightly higher risk, for example, of developing certain types of abnormal heart rhythms like atrial fibrillation, just because of the sort of repetitive strain which they impose onto their hearts. But this is by no means, a suggestion that exercise is a bad thing, and therefore the general advice all around the world is that exercise is beneficial. Even people who have had a heart attack or who have had an important cardiac event should go back to resuming exercise. And there's a huge wealth of evidence showing that cardiac rehabilitation after having sustained a heart event is very important, and that we try as much as possible to get people back to doing good amounts of exercise even after they've had a cardiac event, because of the long-term protective effects that that has on the heart. So I can't overemphasize how crucially important exercise is. And exercise is also important to maintain brain health, by the way. So you're really killing two birds with one stone.
Yes, I guess underlining that, I think it's obviously important to stress that it doesn't have to be athletic levels of exercise, that even moderate levels of exercise, just going for a regular walk each day, is an important contribution to your overall health, as you stress. So yes, so another question that's come up is really about what happens when you've done the scan if you find something that's abnormal. And so how do you deal with that? How do you communicate with the doctors? How do you communicate with the participants about the possibility of an incidental finding?
Absolutely. So this was, of course, one of the things that the Research Ethics Committee wanted to know from us. In other words, what is our protocol for dealing with incidental findings? And here we haven't reinvented the wheel. We do what is considered to be good governance and good duty of care all across the NHS and all across UK research institutions such as ours. And what we typically do is, so looking at, for example, the 4 NSHD participants who've already had their scan, right after this scan, some participants are sometimes keen to actually look at some of the images, and we encourage that, and we are able to show you some of your images if that's something that you would like to see. It usually takes us a few hours to report the large volume of data that gets collected, so we usually do not share any information on the day. But within a maximum of 2 weeks, your scan gets reported. It always gets reported initially by my PhD fellow and then by myself. And if there is an important cardiac finding that is really important and can matter for your clinical care, I usually call you and I tell you about it over the phone, having obviously had your consent for us to contact you for such things prior to you being recruited into the study. In addition, I then call your GP, again with your consent, and I speak to your GP over the phone and tell them about the sort of incidental finding that has been picked up. I then send a letter both to yourself and to the GP with all the details of exactly what sort of abnormality has been picked up, together with my suggestion for how this should be carried forward in terms of investigating it within the NHS. I also want to mention that from our experience, having scanned the first few participants last year, we found that participants usually enjoy knowing something about the cardiac MRI scan, even if there's been nothing really abnormal picked up. And I think that most of you will find that quite useful. So typically, when we send back results letters, for example, that summarize the blood results, we usually send results letters which summarize your blood pressure values when you came to clinic. I usually also include a short paragraph there summarizing the salient findings from your MRI scan. And if it's normal, I tell you so. And we found that this works well for most participants. So again, provided you give us consent, we will continue to do that.
Great, thank you, Gabby. So I'm conscious of time and we're coming towards the end of the session. I should say we've had lots and lots of questions, and I'm sorry that we haven't been able to deal with all of them, but we are going to try and deal with most of them that we haven't had time to answer in this session on the website. So if your question hasn't been answered, I'm sorry, but we will deal with it later. So what I want to do now is to thank all the speakers, John and Sarah and Gabby, and all of you watching. And I think there's around 100 people watching at the moment. So thanks for your questions and your interest in the study. I hope you'll join us tomorrow. Again, tomorrow we'll have another session to describe what's going on in the study, our plans for the future and what's been found. And now we're going to play a special birthday message for you that's been recorded. So thanks very much for watching us.
Hi, my name is Nick Ross, and I almost share a birthday with you, but I wish I could share the credit and deserve this celebration as much as you do. You hardly need me to point out what a magnificent thing you've done for the world of healthcare. One of the hardest things to do in medicine is to see things in the long run. In the old days, of course, it was all hit and miss. And one of my favorite quotes is from the philosopher and wit Voltaire, who pointed out that the art of the great physician in those days was to keep his patient amused until she either got better or died. Thankfully, knowledge has improved hugely since then, but especially since the Second World War, and much of that is down to you. Now, I have a particular interest, not only because I'm involved with the NHS, which I am, and with medical science, but I spent most of my life as a broadcaster and was particularly impressed by that series 7 Up, which followed a cohort of 14 young people from the 1960s. And I know how hard it was to keep all of them involved. Generations to come will be in better health because of your staying power with the National Survey. So a sincere thank you from me, from everyone, and from generations to come for sticking with it.
Well, thanks to Nick for that message. And as I said, hope we see you tomorrow. Goodbye, and I'll close the session. Thanks. Bye.
Okay.